Okay, carrying on in this same vein, we're going to start on chapter 27. And it's very similar to the last lecture we did that was on chapter 31. That whole conversation that we had about peripheral vascular disease and peripheral arterial disease. So this is very similar to the peripheral arterial disease, except it's all specific to the heart. So we call that coronary vascular disease, referring to the heart. So a lot of this, if you reviewed the chapter 31 lecture, a lot of this should be repeat, but we're just going to go into a little bit more depth about the coronary arteries. The reason this chapter is relevant is because cardiac problems, acute coronary syndrome, myocardial infarction, angina is very, very common. You need to recognize the signs and symptoms of people who would be having an MI or angina, why that occurs, and what to do about it. This is very important nursing concepts. Okay, so the first thing I wanted to point out is this thing called metabolic syndrome. This is becoming more and more prevalent in the United States. People that have metabolic syndrome have a majority of these things, and there are 6 triggers, and I think in order to have metabolic syndrome, you have to have 4 of the 6 or something like that, or you don't have to have all of them, but if you have a majority of them, you are considered to have metabolic syndrome. People who have metabolic syndrome are at a much higher increased risk for having an MI. And these are the things. So your patients that have increased insulin resistance, which just makes sense if you'll remember from diabetes, are overweight patients. If they've been overweight for a long time, tend to start developing insulin resistance. This is a precursor to diabetes as well. So these two things, metabolic syndrome, diabetes type 2, and MI all go hand in hand. And this is why. Central obesity. By central obesity, I mean in the trunk. So people that carry a lot of weight in their bellies are at higher risk for metabolic syndrome. High triglycerides. These are your people that eat. They can eat unhealthy, eat fat foods, eat foods that are high in cholesterol, but some people just have genetically high triglyceride levels. So that's the fat component in the blood. People that have high blood pressure, but not necessarily, doesn't have to necessarily be diagnosed as hypertensive, being 140/90, but the ones that kind of run sort of pre-hypertensive in the 130s over 85 range consistently, they're kind of scooting up there a little bit into the to developing metabolic syndrome. High CRP levels, and CRP is a lab value that you get in the serum, in the blood, and it stands for C-reactive protein. C-reactive protein is a protein that is released in the presence of inflammation. So it's not specific to any one area. So if you have a lot of inflammation in your body, you might have higher CRP levels, which means that it could be in the arteries. Remember how we talked about last time that when you have an artery and you start, hang on a second. Oh, so when you have an artery, let me just toss it over there, and it's nice and smooth like this, and all the blood is flowing through it really nice. And then all of a sudden you have this, not all of a sudden, over time, this cholesterol and plaque starts laying down like this. Your arteries don't like that. And the inflammatory process starts. So this starts getting all swollen, making the situation worse because now you're making the diameter of that vessel smaller. So it's making it even harder for more blood to get through there. And then like either the plaque can tear off, you can have bleeding that occurs because it's like a scab, you know, like a scab would get ripped off, something like that. Then more bleeding can occur in here, more inflammation laying down. But all of this inflammation will contribute to high CRP levels. So people that have that also are at higher risk for metabolic syndrome. And then finally, people that have high fibrinogen levels. The reason that this is problematic is because they're more likely to develop clots. So you have this situation where you've got this stuff going on inside the arteries, and people that have higher fibrinogens are going to be more likely to clot in here than people that don't have that. So in the presence of all of these things, patients can get diagnosed with metabolic syndrome. Patients who have metabolic syndrome are significantly higher risk for developing MIs, myocardial infarctions. So you watch for this in your patients and you try to prevent this. Most of this stuff is preventable. You try to get your patient to have healthy weights, healthy diet, like we talked about last time. It's such an important lifestyle modification, but in America it's so very difficult because we are sedentary people and our diet is not very good. So when this starts occurring in the coronary arteries, and this is your heart, this is the left ventricle that squeezes up into the aorta, those branches that come off that aorta come around and feed the heart. The heart muscle has to get blood as well, just like the heart pumps blood to everything, all the other organs. It also feeds itself. There's a really good picture in your book, and this time I double check so I know it's there. On page 731. So I want you to look at that. It's figure 27.2 on page 731, and I want you to look at these arteries that feed the outside of the heart. Specifically, the anterior descending branch of the left coronary artery. I'm talking about this one. That right there. Can you guys see that? That is the major artery that if that gets clogged, and if it gets clogged sufficiently and high enough up, the thing about this that I want to point out, and I don't know if you guys can see it from there or not, I'll come a little closer, but it really matters where in here the clot happens. So if the plaque starts up here, and plaque likes to develop, see how there's that bifurcation right there? Plaque likes to develop in those areas. And see how there's another little branching down here, there? If the plaque happens up here and it causes a blockage there, that's called the widowmaker, because that entire left ventricle there gets ischemic and will quit working very quickly, very, very quickly. But if the clot lands down here, a much smaller section of that myocardium will become ischemic, and smaller is better. You don't want big ischemia in your heart. So anyways, your job as a nurse is to first identify your patients who are at high risk, and then try to adjust anything that's modifiable. Cigarette smoking leads to vasoconstriction. It increases heart rate, increases blood pressure, all things that are going to contribute to myocardial infarction. Weight reduction, healthy food, exercising 30 minutes most days of the week, low sodium diet. These are going to be things that are going to help reduce your patient's risk of developing an MI. And we'll talk a little bit more about an MI in a second. If a patient starts developing this kind of a situation where they've got some plaque buildup, they've got a little bit of high blood pressure, they may have a reduction in blood flow to these coronary arteries, but they still have some. And I think I mentioned this in when I was doing chapter 31. When they have an increase in activity and there is an increased demand for that heart to work, there's an increased oxygen demand on the cardiac muscles. When a person's starting to work more, when they're mowing the lawn, shoveling the snow, this is the problem with shoveling snow is you have people who have been fairly sedentary. It's usually in the winter time. And this happens a lot in Michigan because we get a lot of snow. So people sit inside. We're not outside. You're not getting your cardiovascular exercise in. So they're sitting down. It gets really cold. They go outside, and in cold environments, you're going to have vasoconstriction. That's what the body does to try to keep it to keep the body warm. It vasoconstricts. Well, then all of a sudden a person is out there shoveling. They're doing heavy lifting, requiring significant oxygen for the cardiac muscles, as well as demanding more blood to the larger muscle groups, and they're out shoveling, and all of a sudden it's just way too much for the heart to handle, and it seizes up, and that's when people who are out shoveling snow end up with MIs because of the combination of increased workload coming off of a sedentary situation and a cold environment. So that we see that quite a bit in Michigan. Well, back to angina. So people that have this scenario may start developing pain with exertion, but it doesn't lead to cellular death because there's enough oxygen getting through that is keeping that cardiac muscle alive. There is a medication called nitroglycerin, and it looks like almost like toothpaste, and you put it on a piece of paper, and the prescription is usually like for a 1-inch patch of nitroglycerin or something like that. You can also, nitroglycerin also comes in a sublingual form. You can put it under the tongue. So people that have angina, they're in this situation. A lot of them will wear a nitroglycerin patch every day. So you put like a new patch, you wipe the old stuff off and put a new one on, and it goes in transdermally, and it's a really good drug that causes vasodilation of the coronary artery. So usually you put the nitroglycerin paste somewhere close to the heart, on the arm or just right over the chest or sometimes on the back. And it is a really good vasodilator. Now do be careful if you're a nurse when you're putting this on somebody, because if you get it on your fingers, it will cause vasodilation in you as well. And almost every nurse has done this where they've gotten nitroglycerin on them, and the next thing you know, they've got a headache because they've caused vasodilation. Now they've got a headache because they've got too much blood in the brain. Okay, so this gives you a precursor to a problem inside the arteries, but it is not until this artery becomes completely occluded with a blood clot or cholesterol. Usually in this scenario it's going to be cholesterol, and it will land here depending on how high up it is. So the further down, the smaller the plaque and the further down it goes in the heart, the better off your patient is going to be, because then no blood can get beyond this clot, and then it leads to ischemia. Ischemia is lack of oxygen to anywhere. In this case, it is coronary, the coronary muscle, and then that muscle starts to die. You, as a nurse, need to recognize when this is happening, and you need to tell the difference between like angina and an MI. Because angina, if the patient starts complaining of chest pain, if you can get them to sit down and slow down their breathing, slow down their heart rate, and get some nitroglycerin in them to dilate those arteries, the pain will go away. That's a classic sign that it's just angina. If you have them sit down and you're giving them nitroglycerin and the pain is not going away after 10-15 minutes, they need to call their healthcare provider, because then it's probably something worse. So if it's angina and you give them nitro and the pain goes away with rest, you just keep treating it as nitro or as angina. if not, if it doesn't go away after 15 minutes, your patient needs to be instructed to call the physician because it's probably developed into an MI. The importance with a patient who is having an MI is rapid intervention. So anytime you think a patient is having an MI, they have to get to the hospital very quickly, because there are some medications that can break down those clots and hopefully save somebody's life. They're very potent medications that break down clots, and the other problem is when this event occurs, that's when the heart muscle can actually stop. The patient can go into some of these lethal arrhythmias, VTAC and VFib, and we'll talk about that when we do dysrhythmias, but those things stop the heart from beating, and then no blood can get through, and that's what leads to cardiac death. The difference, I want to go back to angina for a second, because you can have stable angina, and people can live with that for years. People that have angina, they will carry nitroglycerin tablets with them that they can stick under their tongue. The nitroglycerin tablets have to be kept away from the sunlight, because sun deteriorates the nitroglycerin. So it's usually like in a dark container that they carry around. But some patients have unstable angina, meaning that it is more difficult to control. It's not as responsive to nitroglycerin, and those patients who have unstable angina are much more likely for that to convert into an MI. Once the patient has an MI and there is cardiac ischemia, there are some certain markers, identifiable markers, that will give you an indication that it is an MI and not angina. A patient that has angina won't have EKG changes, because the cardiac muscle and the way that the sodium-potassium pump is depolarizing is not affected, because ischemia has not occurred. In your patients that have had a myocardial infarction, ischemia to the heart muscle, you will see changes on the EKG. And the way that you can see it on the EKG is the pattern of depolarization takes longer. And I know this probably doesn't make any sense to you, but I want you to hear these words, because we're going to talk more about it when I teach you about dysrhythmias. So, in your patient who has had an MI, a normal EKG, you have a baseline, and then you have your P wave, which the P wave represents when those atrium are contracting. You don't need to know this right now, but just hear these words, because you're going to need to know it in a couple weeks. So that's your P wave, and then you have this QRS, like this, a QRS wave. That's the big wave when those ventricles are contracting and it's ejecting blood into the pulmonary and the systemic system. And then it comes back to baseline, and then you have a T wave. So this is the P, the atrium, and this is the QRS, that's the ventricles, and this is the T wave. The T wave right here is when these ventricles are resetting themselves. This is during diastole, and it's during repolarization. This is what a normal heart looks like. When a heart has experienced ischemia, like in an MI, it takes longer because these cells are dead, basically. So it takes a lot longer for them to repolarize, to reset themselves. So, and it'll show up here. So usually this takes longer. So then it either doesn't come back to baseline or it gets very elevated. So this one is called a STEMI, a ST, this is the ST segment, ST elevated myocardial infarction, a STEMI. ST elevated MI. Sometimes This doesn't get elevated. Sometimes it just comes back, but you can have something else like called a U wave, or we'll go to, never mind, we'll go into that later. We're going to get too confused. And those are called non-ST elevated MIs, an NSTEMI. So angina patients won't have changes in their EKGs. Myocardial infarcted patients will. And so one way you can tell that it's converted to an MI is EKG changes, specifically a STEMI or sometimes a non-STEMI, but the STEMIs are usually an indication of a worse MI. Not always, but usually. The other thing that when your patient, when you've identified that your patient has coronary artery disease, we have a lot of medications that we can put the patients on. Usually they're on blood thinners, and that can be something as simple like as an aspirin, or they might need something like Coumadin or Lovenox, something like that, the low molecular weight heparins, to keep the blood thins, things that are going to have like anti-platelet properties to them. Another really good class of drugs that is sort of a newer category are the statin drugs. The statin drugs, like Lipitor and those guys, are really good at reducing cholesterol. So people that have high cholesterol, you know, are at risk for this problem, cholesterol buildup and inflammation in the arteries. And if you put them on the statin drugs, that helps to lower their cholesterol. I think there's a really good chart in your book about some of the different coronary meds. Oh yeah, it's on page 735, table 27-2. This is a really good chart to know because tons of your patients are going to be on these meds because they're cholesterol lowering meds. They help reduce fat and cholesterol in the body. So those are really good drugs that a ton of people are on. And then the other one over on page 737 on table 27-3, those are good drugs that are used to treat angina. So patients who are on angina, we try to relax their coronary arteries. We try to reduce the workload of the heart. Things like they're on beta blockers and calcium channel blockers, things like that. Okay. Next, I want to talk about I think I did. I totally forgot to finish this train of thought. So I was going to tell you guys about ways to identify if your patient has angina versus if they have an MI. And one way is in the EKG changes, and then the other way is through the lab work. So if your patient's had an MI, they'll definitely have elevated CRPs. But CRP, like I said earlier, is a very general indicator of inflammation. Troponin levels, T-R-O-P-I-N, troponin is an enzyme that is specific to the cardiac muscle. So in the presence of an elevated troponin, now you know you have cardiac ischemic death. That does not occur in angina. So elevated troponin level is pretty specific to the heart. Back in the day, we used to follow, they were called CKMB, the cardiac bands. And that is, some places still use it, and with CKMBs, you had to get a series of blood draws over 8 hours. So as soon as you thought or suspected that a patient was having an MI, you would draw a set of CKMBs, then you would draw another set of bands 8 hours later, and then draw another one 8 hours after that. So it was a series of 3 over 24 hours. And so you really had to wait 24 hours to determine if the person was actually having a heart attack. You would treat them as if they were, but you couldn't confirm it for 24 hours. Troponin now you can get it once, and if it's there, you know that you've got cardiac ischemia. So there's a couple of lab values that I want you to look at. Those are on page 743. So those are important just because you're going to be a nurse. You're going to see those lab values come back, so you're going to need to know what the heck they're talking about. And then I already told you about, like, if the patient comes in and they're in having a suspected MI, and they'll confirm it. You'll do a 12 lead, you'll get the labs, you can confirm, yes, somebody's having an MI. They will have, they may have chest discomfort. Not everybody has that. Women especially tend to not have traditional cardiac symptoms. But traditional cardiac symptoms, like you can have pain radiating up into the jaw, you can have left-sided chest pain, pain that goes down the arm, and a lot of people, especially if they're having small little infarct weight, you know, in one of the smaller vessels, a lot of people blow off symptoms. They might just feel like a heaviness in their chest. They might feel just sort of like their arm is just sort of heavy, and they'll blow it off because a lot of people think, oh no, I'm not having an MI, I don't have a history of heart attack. Heart attack is the word that your patients will use. Everybody uses the word heart attack. And MI, those are interchangeable, but in the world of medicine, we call it an MI, a myocardial infarction. So anyways, watch for symptoms. If you're with somebody who is having chest pain symptoms, you call 911 right away because time is of the essence. You can give things like aspirin, because that's a really good blood thinner. It also will help control pain, because you do want to control pain. You want to relieve somebody's anxiety because it's very scary, because everybody knows that you can die if you're having an MI. So anxiety goes up, and when anxiety goes up, vasoconstriction happens, cortisol is released, so you want to keep somebody as calm as possible. Morphine is an excellent drug of choice if somebody's having suspected MI, to keep them both calm and keep their pain under control. You want to give them oxygen right away, because this is obviously a lack of oxygen, so we want to help the body by giving them more oxygen, and then hopefully you can get them to the hospital and get that artery opened up as fast as possible using some of the fibrinolytics. And then that's why you also need to always be up to date on your BCLS, because having an MI is the #1 cause of the heart to stop. And if you're there and you can start administering chest compressions, and then if you're in the hospital you can defibrillate the patient, or if you get a defibrillator nearby. And now a lot of places where you are, like schools and shopping malls and stuff, they have those automatic defibrillators. So if somebody has an MI in public, then you can go grab the defibrillator and get that heart back working again, get it out of a lethal arrhythmia. Once a patient has had an MI, this is the problem. This is the big problem. We'll talk about this when we start talking about congestive heart failure. But the problem following the MI is the heart muscle now doesn't work as well. So you can go to cardiac rehab. A lot of them do go to cardiac rehab because you have to rebuild up this heart muscle that's now damaged. Here's the problem. So you have this heart with all of this muscle that was supposed to be doing its job. It's supposed to be delivering 4 to 8 liters of cardiac output every minute. So now all of a sudden, a large section of my major player can't help. It's dead. And it cannot help get the blood out anymore. So now we have a problem. This would be like if you had a cart full of supplies of something, and you're carrying it to your people using a 6-horse drawn carriage. So you've got your big stout horses There's all 6 of them. They're hooked up to the carriage. You've got your big heavy load and you're carrying your load down. All of a sudden a horse dies. But you still have to get the same load to the same amount of people in the same amount of time. So now what happens is those other 5 horses have to pick up the work, or else something's got to give. That's what happens in the event of an MI, is all of a sudden you still have the same amount of work to get accomplished. All those other organs still need their oxygen supply, but now you've just lost part of the engine. So you can do a couple of things. You can do cardiac rehab where that is going to strengthen that cardiac muscle. Then you can also put them on some medications that are going to slow the work of the heart. They're going to dilate the vessels, all the stuff we've already talked about that. And what you're trying to do is make this as efficient as possible in lieu of the fact that there's now some damage. Because patients who have had this scenario occur are now at higher risk for congestive heart failure or left-sided heart failure, meaning this left ventricle can't keep up. And so the fluid keeps coming into the left ventricle from the pulmonary system through the left atrium and then in the left ventricle, but the left ventricle just can't keep up with it. It's kind of like back to my horse scenario where people keep, they keep piling on the stuff on your cart that needs to go, but the horses are just getting exhausted. And so everything starts backing up. You're not unloading the packages, the cart's getting overflowed, the cart starts overflowing with packages. And that's what happens in congestive heart failure. So the blood that is coming back from the pulmonary system into the left atrium is now trying to get to the left ventricle. The left ventricle is too filled up. Preload is really high. And so that's congestive heart failure. And we'll talk about that we're going to talk about heart failure next time. But once you have this scenario of coronary vascular disease, and we talked about this when we were talking about peripheral arterial disease, you can place stents in these arteries. You just put a stent there to keep that opened up. If it's bad enough, the patient might have to have a CABG, a coronary arterial bypass graft. I talked about that in my last lecture. And those are some of those big surgeries, and there's a lot of work to do as a nurse, both during surgery, pre-surgery, post-surgery, and your patients who are having CABGs. So hopefully you read about that or heard about that when we were going over chapter 31. But if not, go back and review that part of the lecture, because I talked a little bit about what they do in a coronary artery bypass graft, how it's done. They take the big vessels or the veins from the legs and just go out around the damaged arteries. So hopefully you'll be able to take care of a patient who's had a CABG. And I think that is about it that I want you to know about having an MI and coronary artery disease. Yeah, that's it. This care plan that's in here is a good one. So if you're taking care of a patient who has cardiac syndrome, or MI, I'd be using that. That's really helpful. So, okay, that's it for chapter 27. All right, that's it. Sweet.